Yeah. So
Thank you.
I will go to my presentation. Mhm. 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 Okay, do you see my presentation?
Yes, Professor.
Yes.
Okay, okay,
You can go ahead.
okay. Thank you. So I'm Dr. Ohuabi from Rabat. This is the Department of Neurosurgery in Rabat. And this is the Rabat CT. For those who has been there, Professor Yoko Kato, Professor Zelili, and I hope the other colleagues will one day are invited to come to Rabat. And this is the new neurosurgical department and the new university hospital under construction in the area. So let's go to the presentation. This one of slides I have presented many times in many congresses, just to a reminder about this ISAT study. This ISAT study had an important impact on the management of aneurysm subarachnoid hemorrhage, despite numerous limitations of the study. The result of that, and there is an decrease in the number of aneurysm cases that has been treated since then by neurosurgeon. The aneurysm referred to neurosurgeon became more difficult and more complex. And also, we are now witnessing a new generation of neurosurgeon, unfortunately less familiar with open surgery. However, with the continuous development of endovascular technique, to decade later, we are still, the debate continues. What is the efficacy and safety of coiling versus clipping? And also the role and the endovascular treatment versus clip-in treatment in the endovascular area. Since the publication of ISAT, there has been 3 studies that have, and many observational studies that shown different results from the initial ISAT study. But still, the continuous development of endovascular made it very widespread and used by many neurosurgeons and neurointerventionists. In addition to this debate, the endovascular treatment, we know that has still many limitations and is not the ideal solution for many rupture aneurysm cases. And the main limitations are, first, the durability, because of higher risks of recurrence with time. The complete obliteration rate is still inferior to the result we obtain after clipping, and this has been shown in many studies. There is a higher complication rates with complex devices, fluid diverters, coiling-assisted with stent. Complex aneurysm, which are technically demanding, is also a problem of difficulty with endovascular treatment. And in many countries, like countries in Africa, the cost and affordability of devices is one of the big limitations of the development endovascular in these countries. And from scientific point of view, non-randomized trial available so far to compare the different devices that have been used for endovascular treatment of aneurysm. This group of complex cerebral aneurysm constitute a poorly defined group of technically demanding lesions. And you have seen the characteristic of this group of complex aneurysm. You see there are different features: giant aneurysm, location, a difficult or mobile position, configuration, broad neck, branches rising from aneurysm, wall structure with blister-like dissection, the calcification aneurysm. So there are many features that make the definition of a complex aneurysm, but still there is no general consensus what is exactly the complex cerebral aneurysm. And in the last few years, there are many authors who try to identify a new group of this kind of aneurysm to be treated with either endovascular or microsurgery or both technique. The complex wide base aneurysm pose a big problem for endovascular treatment. Patient with tortuous vascular anatomy and accessibility is also a problem of limitation of this technique. Aneurysm with important vessels originating from dome or and mycotic and traumatic distal aneurysm, the blister and small aneurysm with the risk of rupture. In most of rupture aneurysms, the use of stent-assisted coiling and flow diverter requires antipyrethroid, what is not safe in this case of rupture aneurysm. And as I said, the cost and affordability of devices also. And when we review the most recent endovascular series with endovascular treatment of complex aneurysm, when compared with the non-complex aneurysm, the total aneurysm occlusion is around 50% versus 70 to 75% in non-complex aneurysm. The recanalization rate is high, and there is very important notion about the rate of aborted procedure. And 25% almost cases cannot be, the interventionist cannot proceed with this technique. And when you have aneurysm that has rupture, the clinical outcome is worse than with non-complex aneurysm. So we review our clinical series to study this kind of aneurysm. And this aneurysm type represent more than 60% of all aneurysm treated on our series. And this is our series. This is an institutional series about 1,173 patients that has been treated. All of them have rupture aneurysm. This is a big problem still in Africa. 90% of patients are referred to us after rupture and not before rupture. So these are two period of treatment before the introduction on the vascular area in our department before 2005, and then after the introduction of the endovascular area in the department after 2005. And you can see here that in the endovascular area, we treated 822 patients. 30% are 70% are clipping and 30% are clipping. And we have compared the two group of this two kind of treatment to see what is the evolution and also the clinical outcome of this case of patient. And there are indication for both technique. We consider that patients are better candidate for clipping if they are young, when last 30 years, dysplasic with and wide neck aneurysm, most MC aneurysm, giant aneurysm, distal aneurysm, compressive hematoma, and patients with present with mass effect on cranial nerve. Those patients we consider that are not suitable for endovascular. Of course, all these patients are discussed with our colleague endovascular. The better candidates for endovascular are posterior circulation aneurysm, poor WFNS grades, old patient with symptomatic vasospasm, and the two techniques can be used without a problem in the small anterior circulation narrow aneurysm with the patient very good grade 1 to 2 or 2. And this, for example, aneurysm that's suitable for both technique, the non-dysplasic narrow neck aneurysm, dome to neck ratio more than 2, and no important vascularization coming from the sac. But these kind of aneurysm we consider complex. More than 65% of all aneurysm treated in our daily practice. And you can see most of them are dysplasic aneurysm, mycotic, distal, small and wide neck, sometimes MC aneurysm, distal A1, A2 aneurysm. So these kind of aneurysm, after discussion with endovascular colleagues, we prefer to go for microsurgery because the results are better than with endovascular treatment. And this is just some illustrative cases about this kind of aneurysm. This is a patient presented with dysplasic right ACOM aneurysm after subarachnoid hemorrhage, and and you can see here. This is the dysplasic right A1, A2 aneurysm. After terminal approach, opening of the Sabian fissure, you can see the optic nerve here, the aneurysm. This is the both I2, dissecting both I2 here. The A1, you see the A1 is dysplasic, and we are going to use mini fenestration clip to reconstruct the A1 and to exclude the aneurysm sac. This is the first case. The second case is this patient presented once again with large ruptures, wide neck ACAM aneurysm, not suitable for endovascular treatment. And we operate the patient. This is with the broad neck. And after dissection of, there is the small resection of gyrus rectus. And then we dissect the sac and try to define the neck of the aneurysm. There is a temporary clip here on A1. We dissect here the sac of aneurysm and separate it from A2, both A2. We use, once again, a fenestrated clip to reconstruct the parent artery and to exclude the sac. And then we make a control with ICG. We found that the clip just take part of A1 contralateral A1, and then we reposition the clip once again to be sure that it is free. And then we performed a last control, ICG control, to be sure that the final control was satisfactory. The third patient is a patient presented with rupture dysplasic and calcified right MCA aneurysm, the bifurcation with wide neck. And we discussed the case with our colleague, and it was not suitable for endovascular treatment. And then opening the Sylvian fissure. The sac is yellow, dysplasic, with some atherosclerotic material inside. We discussed the section of the sac from the M2, M1A2. We try to define a neck. We make some coagulation of the neck just to shrink the sac and to individualize a neck where we can make our clipping. And just to control final control to be sure that the clip doesn't interrupt vascular structure. There is two other patient. This one had presented with internal carotid right internal carotid artery ophthalmic paracnoid which has rupture. And we discuss the case, and we go for microsurgery, and we start by making this is a paraclinoid aneurysm, so we make an anterior cleidoctomy. Intradural cleidoctomy, and we dissect the sac. During this procedure, there's a small rupture of the aneurysm. And once again, we use some fenestrated clip to reconstruct the carotid artery and to exclude the aneurysm sac. Other indication are the when the aneurysm presented with some mass effect on cranial nerve. This is the case of a patient presented with large rupture carotid ophthalmic aneurysm with reduced visual acuity, and we go for microsurgery, and then this is the approach. We performed entoroclinodectomy. And then we dissect the aneurysm. Look, there is the neck here is not very wide here. So we clip the neck, and then we go for a decompression and resection of the sac. This, the microsurgery is better here regarding the outcome of the optic nerve compression than the endovascular treatment. And then we resect completely the sac. So this is also a patient presented with third nerve palsy and rupture aneurysm. So we decide to go for microsurgery. This is a large partially thrombosed aneurysm, become aneurysm, and we after this section, the neck here, that was the clip in the neck was straightforward, was small neck, and then we open the sac to compress the third nerve to be sure that to relieve the pressure on the third nerve. So our indication each time there is a compression of cranial nerve, we prefer to go for microsurgery to decompress. And the last two cases, this is one patient who presented with 13 years boy old with the basilar trunk aneurysm with which was not favorable for coiling, and we decide to go for surgery, and this is the aneurysm, the small one, and after opening this Sylvian fissure and the basal cistern, the Leuquist membrane also was opened, and then we get access to the basilar trunk. And we can see here, this is the small aneurysm that is orientated downward. And we use one small clip to exclude the sac. Thus, we will trying to see what the best approach here. And the last case is a patient presented with rupture basilar trunk aneurysm, not suitable for endovascular treatment. And after opening the Sylvian fissure, we go for dissect. This is the basilar trunk. The temporary clip on the basilar trunk, and then we use a clip, long clip, to exclude the sac, and we control remove the, and we control the aspirate sac to be sure that it completely occluded. That's it. So this is the comparison between the endovascular and the microsurgical clip-in RCD. The clip-in rate of complete collision 30% versus coiling 74%. And this is the outcome between the two groups. There is no difference in good outcome in the two groups. So why microsurgical clipping for fracture aneurysm is still relevant in the area of endovascular? I think there are many reasons. The first one is that clipping is well-established treatment modalities for many, many decades, and there is no difference in clinical outcome with ANSAT and other studies, especially for anterior circulation aneurysm. The second is that clipping is superior to coiling regarding obliteration rate and risk of recurrence in all type of aneurysm. And there is a higher risk of rebleeding after coiling at 10 years. The clipping is the most definitive and durable mean of treatment. The second reason that endovascular technique have still many limitations. The third one is that there is a problem of cost for endovascular versus microsurgery, and you can see in giant aneurysm coiling costs 13 times clipping giant aneurysm. So the debate on coiling versus clipping should be ended. I think there is both endovascular treatment and neurosurgical treatment should be considered as viable option. And we have to think about the patient-tailored treatment strategy should be adopted. So in conclusion, the result of these studies, as many others, shows that in daily clinical practice, clipping and coiling yield to similar good clinical outcome in rupture cerebral aneurysm, provided the selection criteria for each procedure are respected. The clipping is still the best treatment option of complex rupture aneurysm than endovascular treatment. A patient trial or treatment approach in which both endovascular and microsurgery are regarded as viable option is the best treatment strategy in cerebral aneurysm management. A more inclusive approach with combined endovascular and microsurgical is being developed in hybrid operative room for complex cerebral aneurysm. Thank you.